Welcome back, everyone. We'll carry on shortly. Yeah, so a 30-year-old male patient presents to the ER following a road traffic accident. On examination of the hand with palm down, he's unable to abduct the thumb and unable to extend it also against restrictive force. This pattern of presentation is more likely to represent injury to which of the following? Yeah, so there is two problems. Problem number one, unable to abduct the thumb in this way while palm down. And problem number two, unable to extend thumb, right? So what would explain that ruptured tendon, ulnar nerve, median nerve? Yeah, PIN. Right, that's correct. PIN, posterior interosseous nerve, which is a branch of, it's a continuation of the deep branch of the radial nerve. As soon as the deep branch of the radial nerve emerge in the posterior compartment of the forearm between the two heads of the supinator muscle, it will be now called PIN. It's a strictly motor nerve with no cutaneous sensory branch. It has proprioceptive sensory fibers coming from the wrist joint, but no skin sensation. It doesn't give any cutaneous sensation, right? And this is explained by the fact that there is paralysis of the abductor pollicis longus and extensor pollicis longus. Both of them are two muscles in the deep aspect of the Dr. Sayed said can't abduct and extend due to PIN injury. Motor only, no sensation. No cutaneous sensation. No cutaneous sensation. There is proprioceptive sensation carried by PIN, but no cutaneous sensory fibers. Okay, let's see another question. Yeah, loss of supination. Loss of supination. Yeah, musculocutaneous nerve. Musculocutaneous nerve because it supplies biceps brachii, and the biceps brachii is the main supinator of the forearm. Is the main one. Right? The main supinator is the biceps brachii. Brachyradialis. What is the action of brachyradialis? What does it do, this muscle? So Dr. Sarah said mid-prone position, mid-pronation. What does it mean, mid-prone? So it means, yeah, it flicks the elbow in mid-pronation, like when you're shaking hands. When you're shaking hands, right, mid-pronation, and flexes the elbow joint at that particular position, right? So I have a question. When I tell you ulnar nerve, what is the root value for the ulnar nerve? What does it carry? Fibers from where? C8T1 only C8T1, nothing else. Okay, so roots of brachial plexus, C5, C6, C7, C8, T1, all of C5, all of C6, all of C7, all of C8, part of T1, not all of T1. Right? So these are roots of brachial plexus. C5, C6 forms upper trunk. C8, T1 forms lower trunk. C7 forms middle trunk. Then there's the divisions, right? All posterior divisions comes to form posterior cord. Then the anterior division of upper trunk and the anterior division of the middle trunk forms the lateral cord. The anterior division of the lower trunk forms the medial cord, right? And then what's going to happen? And then, of course, there are terminal branches. Terminal branches. The lateral cord gives musculocutaneous nerve and lateral root of median nerve. Lateral root of median nerve. The medial trunk, medial cord gives ulnar nerve and medial root of median nerve. Medial root of median nerve and lateral root of median nerve come together to form median nerve. Right? Posterior cord has many branches, but that's radial nerve. So ulnar nerve would carry fibers from C8 and T1. Is that right? It's like a map. But also, so that's C8, that's T1. But also, you know, from the lateral root of median nerve, some C7 fibers come and jump here. So they actually jump like this. Let me show you. This is C7 fiber. It comes here in the root, and then it goes through the anterior division of the middle trunk, and then enters into the lateral cord, and then it enters into the lateral root of median nerve, and then jumps to the ulnar nerve. Jumps here. So ulnar nerve would contain C7, C8, and T1. Right? C7 is included. Right? C7 fibers. Anyway, let's see another question. No, not all C7. Some fibers from C7. Some of the fibers from C7. Yeah, so following a road traffic accident, 12-year-old boy presents with loss of sensation along the medial arm and forearm, along with weakness of wrists, that is abduction and so on. Yeah, so this is medial cord. The branches from the medial cord, so that's medial cord of brachial plexus. What are the branches? Medial cutaneous nerve of arm, medial cutaneous nerve of arm, medial cutaneous nerve of forearm. This is also called medial cutaneous brachial nerve. This is also called medial cutaneous antebrachial. Anyway, and then there is medial pectoral nerve. And then there is ulnar nerve and medial root of median nerve. Right? These are the branches. And of course, you can relate that to the case. It's very clear. That is the medial cord of the brachial plexus that is being injured here. Okay. Let's move to another question. Yes, that's correct. The flexor digitorum profundus is the only muscle which inserts at the palmar aspect of the base of the distal phalanx, right, of the medial forefingers. It is the only one that does so, So it is the only one that is able to flex the distal interphalangeal joints of these fingers, right? And it's an established clinical test that you stabilize the middle phalanx of a particular finger and ask the patient to flex this finger. It means flex the distal IP joint, interphalangeal joint. Right, let's move to another question. Yeah, so a 47-year-old woman is undergoing axillary lymph node dissection after a positive sentinel lymph node biopsy for invasive ductal cancer. Yeah, so the question asks what? I'm very impressed, like all the time when I do a session, the speed, the candidates, they read very quickly. That's good for the exam. But also, you can say, within the exam itself and the stress of the exam, it is advisable like to study it. You can read the question slowly, no problem. 1 minute is usually sufficient. Most common nerve injured is intercostal brachial nerve. It comes from where, this nerve? What is the origin of this nerve? It is from, T2. It is the lateral cutaneous branch of the second intercostal nerve. And it is the only nerve, or the only structure, that enters the axilla from its medial wall. There's no other structure that enters the axilla from the medial wall of the axilla. Now, so it's level 1, right? When we do sentinel lymph node biopsy, it entails level 1 dissection. What does it mean, level 1? Level 1 means what? Yeah, level 1 means below the level of pectoralis minor muscle. Level 2 behind the muscle, and level 3 above the muscle. Level 2 is usually carried on if there's positive nodes in level 1. Level 3 dissection is usually not carried out nowadays, right? What is the upper limit surgically for axillary lymph node dissection? Like what kind of structure that you use? Yeah, the axillary vein. The axillary vein is the upper limit for surgical dissection. Why? Because superior to the axillary vein, there are a lot of important structures, right? The axillary artery, cords, brachial plexus, divisions of brachial plexus. There's high likelihood of injury if you dissect superior to the axillary vein. Can you repeat the levels? Yeah, no problem. So look here. So that is coracoid process, simplified diagram. That's coracoid process, right? Here is the lateral chest wall, and that is pectoralis minor. This is pectoralis minor muscle. Pectoralis minor comes from the reps, goes suprolaterally, and inserts onto the coracoid process of the scapula, right? And that's the rest of the humerus, right? And that's the humerus. Now the thing is that level 1 is here. Level 1 is below the level of this muscle, pectoralis minor, below it. Level 2 is behind it, and level 3 is superior to it, right? As simple as that. Yeah. Let's see another question. You know, this next question is super famous and comes in, anyway, for this session, I've selected the most famous questions anyway. So that's a very famous question, which is the relationship of the ulnar nerve to the ulnar artery at the wrist. B is what? B is ulnar artery is ulnar to ulnar nerve. No, ulnar artery is not ulnar to ulnar nerve. Ulnar artery is lateral, that is, it is radial, right? Let me show you. So that is the anterior aspect of the wrist, simplified diagram. That's the thumb, right? And bad adjunct, so that's the hand, right? Now, that's the wrist. Here's suppose that's the pisiform bone, medially, right? The arch, that's what kind of muscle that inserts here? What muscle comes and inserts here? There's a tendon here. That's the tendon for what? What muscle? Inserts initially first at the pisiform and then with some ligaments, pisohamate and pisometacarpal. Yeah, flexor carpial nerves. Flexor carpial nerves. The artery, the nerve, sorry, it is immediately lateral to this tendon and it's tucked under its medial lip. It's under it. So that's why it's difficult here to injure it at that location. But anyway, that's the ulnar nerve. And then the ulnar nerve is lateral to the pisiform. Also, this relationship could be asked about. It is lateral to the pisiform. The ulnar artery, it is it clear, this diagram, right? No problem. So that's ulnar artery. Ulnar artery, it's lateral to the ulnar nerve. So you can say this in a different ways. You can say that the ulnar nerve is ulnar to the ulnar artery. That's a correct statement. Ulnar nerve is medial to the ulnar artery. Also correct statement. Ulnar artery is lateral to the ulnar nerve. Correct. Ulnar artery is radial to the ulnar nerve. Also correct. Right? They just play with words and try to confuse you. But the thing is, it remains the same. So the answer is A. That is, ulnar artery is radial. It is lateral, radial, on the radial side of the nerve, of the ulnar nerve. There's also here, you can say on the other side of the forearm, on the lateral side of the forearm, there is another nerve and another artery, right? That's the, what's that? What's this? Radial artery, right? And lateral to it, what's the nerve which is lateral to it here? It disappears here, this nerve. It doesn't really come to the rest, all the way to the rest. It disappears somewhere in the distal forearm. But it's there in the anterior compartment, at least in a large part of its course. What's this nerve? Yes. Yes, Dr. Puja, both of them, they are lateral to the pisiform. That's correct. Yeah, that's the superficial branch of radial nerve. This is the superficial branch. So they may ask you about this superficial branch of radial nerve, right? Which is sensory. It is totally sensory nerve. Now the thing is that this nerve, it will pass posteriorly deep to the tendon of brachioradialis and goes to the posterior compartment or posterior aspect of the forearm and cross onto or on top of the roof of the anatomical snuff box to enter and supply the dorsal aspect of the hand, sensory supply. It is, of course, radial to the radial artery, right? Right or no? It's radial to radial artery. That's correct, right? Or lateral to the radial artery. So you have to just practice on that. They can confuse you in the exam, stress of exam, things like that. You may get confused about that. So let's now begin with the questions on the anatomy of the thorax. Okay, we finished upper limb things. Now let's go to anatomy of thorax. Yes, first question here. "19-year-old patient presents with stab wound, right? Below third cartilage, below third costal cartilage, 2 cm and to the right of the sternal angle." Of course, that's the surface anatomy or marking for the right atrium. The majority of the anterior surface of the heart is right ventricle. Some right atrium on the right side, anterior surface, right, of the heart. The right atrium is opposite what cartilages? Like, what is the surface anatomy for the right atrium? Like, it extends from where to where, right? What is the superior limit and what is the inferior limit of the right atrium? Yes, superior limit and inferior limit of right atrium. Any idea? Okay, let me tell you. So this is manubrium, right, of the sternum. This is the body of the sternum. This is xiphisternum, right? So at this level, manubriosternal junction, that's second cartilage, right? Second rib here, right? And that is third rib, fourth. Of course, it's not exactly anatomical, but it's just for clarification, that's it. And that's the fourth rib. So this is, what is this rib? Second. This is third. This is fourth. This is fifth. Fifth rib. So that's first space. That's second space. Third space. Fourth space. Fifth space. And so on. The right atrium is on the right of the sternum. Here, parasternally. Where exactly it extends, usually the superior limit, is third cartilage here, level of third cartilage, down to the level of the fifth cartilage. All of this is right atrium. Right? The superior limit is third cartilage, lower limit is fifth cartilage, or even fifth space. Okay, so any stab in this area is more likely to injure the right atrium. Okay, anyway, let's see another question. Yeah, vertebral artery is a branch of the first part of the subclavian artery. Correctly said. Very correct. Okay, let's see another question. Yeah, 50-year-old man sustains a stab. It's immediately to the right of the sternal angle, just to the right of it. So, what's going to be the answer to this one? So, let me send a cadaveric section here. I believe I have that. So this is in the junction between the superior and inferior mediastinum, right? So let's examine like the first option here, which is brachiocephalic vein. We have right and left brachiocephalic veins, right? The right one, so this is the sternum, manubrium of the sternum, right? Here's the body of the sternum. The stab is here, right? Immediately to the right of the sternal angle. So the right brachiocephalic vein forms opposite the right sternoclavicular joint here. So this is right. So this is right subclavian, right internal jugular. Here it's formed opposite the right sternoclavicular articulation and enters into the superior mediastinum. The left one, similar fashion. This is the left subclavian, left internal jugular, and then it is opposite that. The left one is longer and it is going more obliquely downwards, right? Until it fuses here and forms superior vena cava. Superior vena cava is formed within the superior mediastinum before it enters, right? So the level of the stab is clearly below the level of the brachiocephalic veins. It cannot be the answer. And brachiocephalic veins are largely protected behind the manubrium of the sternum also. So this cannot be the answer. Let me show you a cadaveric section and then you will tell me. So this, or a very close representation of that. Let me show you. Okay. I don't know if you can see that, but I've posted it to the... Can you see the image? So, as you can see, posteriorly that's the vertebral column, anteriorly that's the sternum. What is behind the sternum? What is extending behind the sternum at the level of that particular area? That is, you know, the pleura. The pleura, they have two recesses. They have an anterior recess, you can say, and an inferior recess. The anterior one is called, the inferior one is called the costodiaphragmatic recess, right? So it is, this recess is where pleura does not contain lung, okay? It's just pleura. And for example, the lungs, they extend anteriorly about the level of what space, or what is the lungs, like the inferior limit of the lungs anteriorly. What is that limit? Where does it end? Surface anatomy marking, I mean. Yeah, sixth space, right? Sixth intercostal space. And in the mid-axillary line, eighth intercostal space. And posteriorly, T12, right? The pleura extend two spaces below that. Okay, so it really comes down to two spaces below that. For example, anteriorly, sixth space, it becomes eighth space. Mid-axillary line becomes, that is, two spaces below 8, which is 10th, and so on. Sorry, that's T10, by the way, not T12. And posteriorly T12, right? So that is the inferior limit of the pleura, okay? So the inferior limit of the lung, 6, 8, 10. The inferior limit of the pleura, that's going to be, that is 8, 10, 12. 8, 10, 12, two spaces below. So that's the recess here. But there's also anterior recess, in which, let me show you. So this is lung, and this is the other lung, right? And that is somewhere here, sternum, right? Look, some of the pleura actually extends behind the sternum, especially in the superior mediastinum, okay? They don't usually touch, but they come very, very close to each other, just behind the sternum. The stab is here. So usually, almost always, it's going to injure, almost certainly, right pleura, right? The right pleura, because it's the most anterior structure at this particular level. It is the most anterior structure, right? So you can see it also on the image here. It is the most anterior structure at this cross-section, at the cross-section between the superior mediastinum and inferior mediastinum. Okay, so do you agree? It's option E. Everyone agrees? Okay. Let's see another question. Yeah, during the course, left lateral thoracotomy, the surgeon places a clamp across the hilum of the left lung. Which structure would be immediately, of course, it is vagus, which is structure that is immediately anterior. The one that is immediately anterior is going to be phrenic, right? So that's the, look, that's the hilum of the lung. Now, I want to really highlight a very important point. Many people get this wrong. So that's hilum lung, right? Cross-section in the hilum. What is the meaning of that? Hilum or root of lung. It is that area that is enclosed inside the pleural reflections, right? Not outside that. So if they say posterior to hilum, they mean outside the hilum. That's going to be, you know, vagus. Vagus is here. Vagus nerve is running here. Right? That's vagus nerve. And anterior, that's phrenic nerve. They may tell you which structure is most posterior in the hilum. That's different. That's a different question. So if they tell you which structure is posterior to hilum, that's going to be vagus. Which structure is most posterior in the hilum? It means inside here, not outside. Right? What's going to be the answer for this one? Yeah, the bronchi. The main bronchi are the most posterior structure in the hilum. That's correct. Right? The main bronchi are here. Right? The pulmonary veins, where are they? The pulmonary veins, usually there are two ones in each one. So there's superior and inferior pulmonary veins. They are antro-inferior, right? And the pulmonary artery, it's generally antro-superior. Or no, am I wrong? Right, it's here. Pulmonary artery branch is antro-superior, right? That's correct. Hello? Yeah. So is this relationship correct or no? That's bronchus. That's pulmonary artery. That's pulmonary veins, right? Yeah, that's right. Okay, let's see another question. So that is the intercostal nerves. They are the ones that provide sensory supply to the costal pleura. The mediastinal pleura, that is supplied, sensory supply of mediastinal pleura is by what nerve? Phrenic, also diaphragmatic, mostly phrenic, right? Phrenic nerve, also the fibrous pericardium, sensory supply, also phrenic, right? Okay. Let's see this question. Right, during a right lower lobectomy procedure on a 56-year-old man with carcinoma, the mediastinal surface of the lung has to be explored. What structure is going to be posterior to the root of the lung? Right, so everyone agrees it's esophagus, which is quite correct. The mediastinal surface of the right lung. I'm gonna draw it, right, and tell you and ask you which structure is anterior or posterior, and then you'll identify this structure. So that's how can I start with this? Okay, so that's, suppose, mediastinal surface of the right lung. What is the structure here? Coming down, and then it's like that. So this structure is what? Right, extending down. This is a pleural reflection, extending down from the lung hilum, downward like that. This is referred to as pulmonary ligament, right? Pulmonary ligament. And that's the hilum. Okay, so here, immediately posterior, right? So suppose immediately posterior, that's the esophagus, right? Immediately posterior. And then behind the esophagus, behind it immediately, there is a venous structure coming here, coming here, and then going lateral to the esophagus and arching forward like this. What is this structure? Yes, this one. Yes, this is the azygous vein, and this is the arch of azygous vein. This is arch of azygous vein. So it arches superior to the, and then drains anteriorly here where, what's that? That's, what is the structure in which it drains to? This is superior vena cava, correct, nice, right? And what is immediately anterior to this one? Anterior here. Structure anterior here. It's going to be the heart here, the atria, right? The atria are immediately anterior. And then inferiorly, that is inferior vena cava, right? Vagus nerve is, it's difficult to draw here, but it's running posteriorly like this, right? Also posterior to the hilum, right? The left lung, if they ask a similar question, left lung, what's going to be the answer? And vagus is not there. Vagus nerve is not there in the options. So they just said posterior to the hilum of the left lung and no vagus. Yeah, thoracic aorta, right? Because thoracic aorta is tilting more toward the left. It is against the left lung more than the right lung. Okay? Okay, let's see another question. Yeah. So the question asks, the right coronary, right? What's the correct statement about it? Arises from the anterior surface of the ascending aorta. That's a correct statement. Yeah, it arises from the anterior surface of the ascending aorta. Correct. Most people are right dominant coronary circulation or left dominant. The majority of people in the world. Yeah, majority of them are right dominant. What does it mean right dominant? And what does it mean left dominant? Yeah, posterior interventricular artery. Yeah, so any artery, right or left, that supplies the posterior interventricular artery is going to be the dominant one. In most of the people, the posterior interventricular artery comes from the right coronary. So that's why most people are right dominant circulation, right? If it comes from the left, we will call this person left dominant circulation. That's why if there is some kind of situation, for example, if I tell you dissection of the ascending aorta, right? Aortic dissection. In the old days, they were saying abdominal aorta, the dissecting aneurysm. It's not an actual aneurysm, so it's a false statement that has been largely forgotten. So they just say aortic dissection. What is the most common vessel affected in this condition? That was a question in September last exam, by the way. The first branch which is usually affected in ascending aortic dissection? Excellent. Right coronary artery. Right coronary artery. So if most people are right dominant and the right coronary artery is affected, what kind of pattern on the ECG would you see? Yeah, that's excellent, Dr. Isam. That's inferior MI, inferior myocardial infarction, ST elevation in the inferior leads, right? ST elevation, inferior leads. Yeah, and AVF, that's correct. 2-3 AVF. Right, let's see another question. Yes. So, which statement is not right when describing the sinoatrial? No, which statement is right in describing the sinoatrial node? That's the question. Right? Yes. So, it's not part of the somatic system. It's usually supplied by the right coronary. It lies in the right atrium, at the junction of the superior vena cava with the right atrium. Right? And of course, it receives fibers from the vagus nerve. The ventricles don't have parasympathetic supply. That's important to understand. The ventricles are only supplied by sympathetic nervous system, right? You know, the SA node, the atria, and the AV node. They are all supplied, they all receive fibers from the parasympathetic nervous system, but not ventricles. And that's, subhanAllah, it's a protective mechanism. It's a protective mechanism. Suppose if somebody have intense vagal stimulation, their ventricles will stop, or they would develop very severe bradycardia. But if somebody, if the ventricles are not supplied, even when there is marked atrial depression, there's something called escape rhythm, right? The ventricles can create their own pacemaker, maybe from the bundle of Hess, maybe even distal to that, and they can operate on it, operate on that, right? So like nodal rhythm. By the way, if I ask you in case that's unrelated to this session, right? It's a physiology question. You know, GVP waveform, right? It's very important topic, extremely important topic. GVP waveform, the jugular venous pulse. Of course, you have A wave. A wave, that's representative of what thing? Atrial contraction, right? A wave. And then there is C wave, which is representative of closure of the tricuspid valve. And then you have a descent here, and then you have V wave. V wave means what? Filling of atria. Atria is too full, it cannot accommodate anymore, right? And then there is another descent. That's X descent, that's Y descent. So, for example, what is the cause of a giant A wave or big canon A wave? Let's say canon A wave. Canon A wave. Heart block. But you know why there is a canon A wave? Because tricuspid stress causes large A wave, okay, or giant A wave, but not canon A wave. Canon A wave means the atrium contract against a closed valve. Closed, completely closed valve, not stenosed valve, completely closed. That is going to be heart block, because why in heart block? Heart block, the complete heart block, the atria contract on the usually nodal rhythm, SA node, and the ventricles contract on a different rhythm. They operate on different rhythms, right? So this one, for example, the atria, say it contracts 100 beats per minute. The ventricles, let's suppose it contracts 60 beats per minute. They have different pacemakers. So it would be by chance that the atria contract and the ventricle contract simultaneously. Right? So the atria will find itself contracting against a closed ventricle. But that is beat, some beats canon, some beats normal, because it's by chance. It depends on, it's by chance, right? But what if I tell you there's a canon wave in every beat? What's going to be the answer? In every beat, every cardiac cycle, there's a canon wave. Yes? Any idea? Canon wave with every beat. This, we've talked about this in heart block. Some beats, yes, some beats, no. So we've agreed stenosis is not going to cause cannon wave. It's just going to cause a large wave, but not extremely large like a cannon wave. That is nodal rhythm. Nodal rhythm. What's the deal? What's happening here? Let me show you. Right? This is atria, ventricles. Here's the AV node. In nodal rhythm, the AV node is the pacemaker of the heart. And it will give a beat simultaneously to the atria as well as to the ventricles. So all the time, atria and ventricles are contracting in the exact same moment. So all the time, the atria are contracting against a closed ventricle, right? So with every beat, there's going to be a cannon, a wave, right? That is AV nodal rhythm, nodal rhythm. Anyway, okay, just it's unrelated to the session, just came to my mind. Let's see another question. Yeah, these stations are important. You're correct. It's option D. And these stations, I advise everyone to learn them. That is the cricopharyngeal junction. It is 15 centimeters from the incisor teeth. The aortic and bronchial constrictions around 25 centimeters. And then the esophagus passes through the diaphragm at about 40 centimeters, right? In the adults, of course, not in the children. So if I tell you like the esophagus passes through the diaphragm, like exactly where? Not the level, I mean which part of the diaphragm, right? Exactly where does it pass? I mean, is it through the central tendon, through the muscle part, through the right crust, through the left crust? Yeah, through the muscle part of the right crust of the diaphragm, right? That's correct. Okay, let's see another question. A radiologist is contemplating a CT-guided biopsy, middle lobe of the lung. What is the... Yeah, it's B, right? Fourth interspace mid-clavicular line. If you want to take a biopsy from the upper lobe of the lung, what space would you use as standard? Yes, that's very nice, Dr. Pooja. It's third interspace at mid-clavicular line. If I tell you biopsy of lower lobe, that's going to be biopsy of lower lobe, right lung. What surface mark that is considered standard? Yeah, very excellent. Sixth intercostal space at the posterior axillary line. At the posterior axillary line. Very nice. Okay, let's see another question. Because you know, posterior axillary line, because the lower lobes of both lungs, they are largely posterior, not anterior, right? They are from behind, right? Let's see another question. A 23-year-old man is brought to the emergency department penetrating anterior chest wound. What is, correct statement? Anterior surface of the heart. So, yeah. Anterior surface of the heart. What is the correct statement? So it is not, the anterior surface of the heart is not related directly to the diaphragm. The anterior surface of the heart is, sternum and costal cartilages and so on. So some people answered E. It is mainly formed by the right atrium and right ventricle. Yes, that's correct. Mainly formed. What about option B? Option B, it has the coronary sinus passing across it. Yes or no? Yeah? No. Yes, no. Because the coronary sinus runs posteriorly. but be careful. They may say coronary sulcus. If it is option B, like it has a coronary sulcus passing across it, would be true, yes or no? Yes, because the coronary sulcus, some part of it is anterior, some part of it is posterior, right? But the coronary sinus is only posterior. It cannot be anterior. So these were the questions for thoracic anatomy or thorax. Let's now start with questions on cardiothoracic surgery. Or do you need rest? Do you need like 10-minute rest and then we will continue, yes? Okay, 10-minute rest and then we will start with cardiothoracic surgery questions. Thank you, guys.